Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 431 of our pharmacotherapy series, which majors in adverse effects of chemotherapy and targeted agents. The next case reads, JUD, a 56-year-old man, has received 2 courses of therapy with cytarabine for acute myeloid leukemia. Before his therapy was started, his liver function tests and coagulation studies were within normal limits. His current laboratory values on day 10 of his second cycle of high-dose cytarabine include the following. Aspartate aminotransferase is 204 units per liter. Alanine aminotransferase is 197 units per liter. Lactate dehydrogenase is 795 units per liter. Alkaline phosphatase is 285 units per liter. Bilirubin is 1.2 mg per deciliter. So my question to you is, why could JUD's cytarabine be responsible for these laboratory abnormalities? Elevated liver function tests occur frequently in cancer patients. Other signs and symptoms of hepatotoxicity include jaundice, nausea, vomiting, abdominal pain, and, rarely, encephalopathy. Patients should receive an extensive workup to determine whether they require immediate attention for tumor involvement of the liver or possible infection. In addition, patients should discontinue any non-essential medications that can potentially cause hepatotoxicity. The clinician may also discontinue chemotherapy if this is the suspected cause. Several anti-cancer agents, including cytarabine, have been associated with hepatocellular damage. Some agents commonly associated with hepatotoxicity include asparaginase A, carmustine, cytarabine, mercaptopurine, methotrexate, irinotecan, oxaliplatin, clofarabine, and imatinib. A review of 537 cancer patients with tyrosine kinase-associated liver enzyme elevations observed that clinically significant abnormalities were unusual and transient. Multiple agents have black box warnings regarding potential hepatotoxicity. The onset of hepatotoxicity with these drugs is usually within 2 months of treatment initiation and is reversible in the majority of cases. Although death from hepatotoxicity in these cases is uncommon, there have been reports of cirrhosis. All of these drugs come in contact with the liver by entering the liver's blood supply. The liver uniquely receives a dual blood supply from the portal and superior mesenteric veins. The liver detoxifies or inactivates noxious substances and metabolizes many anti-cancer agents. The exact mechanisms by which cytotoxic and targeted agents cause hepatotoxicity are unknown, but most agents probably cause it by a. interfering with the mitochondrial function of the hepatocyte. B. Depleting hepatic glutathione stores. C. Eliciting hypersensitivity reactions. D. Decreasing bile flow. Or E. Causing phlebitis of the central hepatic vein to produce sinusoidal obstructive syndrome, also known as veno-occlusive disease. Several articles serve as excellent resources for anti-cancer therapy-induced hepatotoxicity. Several laboratory tests can serve as indicators of liver structure and function. Serum transaminases, alkaline phosphatase, and bilirubin levels should be monitored routinely in patients receiving hepatotoxic chemotherapy. Although these laboratory indices are sensitive, they are nonspecific for the type of liver disease and do not necessarily correlate with hepatic function. Serum levels of proteins produced by the liver, e.g., ferritin, albumin, prealbumin, or retinol-binding protein, also may be helpful in assessing liver function. The decision to continue or discontinue chemotherapy in patients with apparent hepatic dysfunction can be difficult. If the chemotherapy is the suspected cause, therapy should be withheld until liver function tests are within normal ranges. The clinician should also consider alternative, non-hepatotoxic, chemotherapy for future treatment. In addition, agents that are cleared predominantly via the liver may require dosage adjustments and should be administered cautiously. JUD's cytarabine is likely responsible for his elevated liver enzymes. Therefore, costly workup should be deferred to allow recovery of liver function. Recovery should occur within 2 weeks of chemotherapy. If full recovery does not occur, further therapy, that is agents, doses, or both, may require modifications. The next case reads, THD, a 55-year-old woman, was diagnosed with an early-stage breast cancer and successfully treated with radical mastectomy followed by 4 cycles of adjuvant AC, that is doxorubicin dosed at 60 mg per meter squared IV on day 1, cyclophosphamide 600 mg per meter squared IV on day 1. 18 months after her breast cancer therapy was completed, THD presents to her primary care physician with complaints of fatigue, shortness of breath, easy bruising, and sinusitis. A peripheral blood smear shows a WBC count of 120,000 cells per microliter with a differential of greater than 90% leukemic blasts, and a bone marrow biopsy confirms acute myeloid leukemia, abbreviated as AML. Subsequent cytogenetic analysis revealed abnormalities involving chromosome 11q23. So my question to you reads, what factors support the diagnosis of anti-cancer therapy-associated acute leukemia in THD? Acute leukemia has been associated with cytotoxic therapies used to treat hematologic malignancies, solid tumors, and non-malignant diseases. It has been reported after combination chemotherapy that involves topoisomerase inhibitors, including etoposide and anthracyclines. These leukemias usually occur 1 to 3 years after the completion of chemotherapy, and myelodysplasia does not usually occur before the leukemia. Other characteristics include chromosomal abnormalities involving chromosome 11q23. This challenge is an important area for research given the widespread use of these agents for many curable diseases such as Hodgkin lymphoma, breast cancer, and testicular cancer. Acute myeloid leukemia has also been reported in patients who have had previous exposure to alkylating agents. It usually occurs 5 to 7 years after the patient finishes chemotherapy. Myelodysplastic syndrome, that is pre-leukemia changes, commonly occurs in 50% of patients before overt acute leukemia. Although all alkylating agents can cause acute leukemia, melphalan appears to be the most potent leukemogenic agent in this class. Other classes of chemotherapy agents do not appear to carry as significant a risk. Large doses, continuous daily dosing, prolonged treatment periods, age older than 40 years, and concomitant radiation therapy may increase the risk of exhibiting acute leukemia. Several additional factors may increase a patient's risk of exhibiting acute leukemia. Evidence that cytotoxic agents can cause secondary lymphoid malignancies, particularly non-Hodgkin lymphoma, is also strong. Immunosuppression from the disease and its treatment rather than the particular agent may be the primary cause of non-Hodgkin lymphoma. Other secondary malignancies can occur after anti-cancer treatment as well. Solid tumors have been associated with superficial bladder cancer in patients treated with daily oral cyclophosphamide, and bone sarcoma has occurred after treatment with alkylating agents. The secondary solid tumors in patients treated with other cytotoxic agents are considered coincidental. THD's AML probably occurred secondary to her previous doxorubicin. The chemotherapy agent, as well as the time course for her acute leukemia, is consistent with topoisomerase II agent-induced malignancies. The use of adjuvant AC has been associated with an acute leukemia incidence of 0.2%. In addition, cytogenetic abnormalities occur in more than 90% of those patients who have received chemotherapy or radiation therapy and have subsequently experienced therapy-related myelodysplastic syndrome or AML. Abnormalities in chromosome 11q23 are involved in many of the cases with cytogenetic abnormalities from topoisomerase inhibitors. The chromosomal abnormalities of 11q23 in THD strongly support the diagnosis of chemotherapy-associated acute leukemia rather than de novo leukemia. My next question to you reads: are the therapy and prognosis of THD with treatment-associated AML similar to those of patients with de novo AML? Therapy for patients with treatment-associated AML is much less effective than that of patients with de novo leukemia. Complete remissions with standard cytarabine and daunorubicin regimens are obtained in less than half of patients with treatment-associated AML, compared with a complete remission rate of 70% to 80% in patients with de novo leukemia. The best treatment of therapy-associated AML is prevention. In patients such as THD receiving adjuvant chemotherapy for a curable malignancy, avoiding the use of agents that cause treatment-related AML should be discussed in conjunction with the benefits of therapy. Use of alternative regimens is increasing as more is learned about secondary leukemias. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 432.